Thank everyone for coming initially. Again, my name is Peter Netzler. I will try to keep talking loud, but it might fluctuate throughout. So if you can't hear me, just give me that, especially you guys in the back. So, or that, and I'll leave if we don't want to talk about whatever. So again, my name is Peter Netzler. I grew up in Rock Hill, South Carolina. I went to undergrad in Greenville at Furman University, and then went down to Charleston and did all my medical training down there. So med school, internal medicine residency, cardiology, and then finally, as my wife says, finally EP, or electrophysiology. I am an electrician, so I don't deal, when you think of cardiologists, normally people think of the plumbing, okay, heart attacks, stents, that type of thing. I decided not to go that route, and one of my passions is atrial fibrillation. This is Atrial Fibrillation Month, and that's what we're going to talk about today. So I'll kind of go through my slides, and at the end we'll go through any questions that you guys might have or that might come up throughout the talk. So again, today we're going to talk about gut rhythm, atrial fibrillation, how it can be controlled. So learning points. So you guys have all these on your piece of paper, but we're going to talk about the pathophysiology of atrial fibrillation, the prevalence, symptoms, diagnosis, treatment, different types of treatment, and different avenues that we can pursue, and then we'll go through any questions at the end. So what is atrial fibrillation? Atrial fibrillation is an irregular and often rapid heart rate. It can sometimes cause poor blood flow to the body. And what happens is the heart's two upper chambers that we call the atrium or the atria beat chaotically and irregularly, and they're beating out of coordination with the two lower chambers or the ventricles. And there can be a disconnect. So on these cartoons of the heart, if you guys see me in clinic or know anyone that's seen me, I'm a very bad artist, and so it's better when I have pictures that someone else has drawn up there. But in normal rhythm, the electrical rhythm starts in the top right of the heart, what we call the sinus node. Okay? The electrical signal goes down through the middle, kind of right through this middle part, what we call the AV node, and the AV node's like a toll booth on a highway. A car comes into that toll booth, the toll booth lets it out one at a time. So the electrical signal starts in the sinus node, goes down to the middle through this toll booth, and then finally gets sent down to the bottom. That's in normal rhythm. And the sinus node is built to run between 50 and 100 beats a minute on average. Nothing's too slow unless you feel bad, but that's kind of the norm. And so that's why our heart rate is normally between 50 and 100. In atrial fibrillation, though, if you imagine the top of the heart, the two top chambers of the heart, like a pond, you throw a pebble into that pond, you see the ripple effect going out across the surface of the water. Imagine if 2 or 3 pebbles got thrown in the same time, and those ripples were now all colliding with each other. Or imagine that it's raining on the surface of the water, and it's chaotic on the surface. Well, that's what's happening in the top of the heart chambers in atrial fibrillation. So you have hundreds of beats bombarding this atrium and trying to attack or go through this AV node all at once. The AV node finally gets overwhelmed. Since it's used to accepting only one signal at a time, it's now accepting hundreds. And so it lets a lot of those through. And it lets those signals through in a rapid, sometimes in an irregular manner. And that's why you can feel symptoms with AFib. The bottom of the heart is what you're feeling, very rapid. That's what's causing that heart rate to go fast and irregular. Who does this affect? It affects 2.2 million people in the U.S. and approximately 5 million people worldwide. It increases dramatically with age, occurring in 2.3% of people over age 40, relatively rare, up to 6% of people over age 65. And as we reach our 8th decade of life, almost 10% of the population deals with atrial fibrillation. Unlike cardiac disease or coronary disease, this affects men and women approximately equally. This is just a cartoon. So as our population ages, or as they gain wisdom, okay, we have less and less patients around, but there's more and more patients with atrial fibrillation. So it's increasing in our populations. So what does it feel like? People can feel tired, fatigued, they can feel their heart racing, palpitations or fluttering feelings. They can feel short of breath. DOE, which stands for dyspnea on exertion, it just means when you walk, you feel short of breath. Dizziness, lightheadedness, near syncope, which just means almost passing out. Chest discomfort, generalized uneasiness or anxiety. The worst is when there's no symptoms at all and our first presenting symptom is a stroke. And so that's one of the things we'll talk about. So what causes AFib? There's a whole litany of possibilities that can cause AFib, and that's one of the frustrating things because people have AFib and say, I don't do any of these things, I don't have any of these problems, but I have AFib. What gives? Alcohol can cause it. We call it holiday heart. People go out, binge drink on a Friday night, and Saturday morning come into the emergency room because they're in AFib. That's usually the younger population. Hypertension, hyperthyroidism, sometimes even hypothyroidism, heart surgery or any type of surgery, valvular heart disease, which can be a marker of disease progression, a cardiomyopathy, stimulants, stress, caffeine, and cold medications, pericardial disease, chronic lung disease, pulmonary embolism, and obesity, and even obstructive sleep apnea is a big thing. Also, genetics. Most people, I get this whole list and they say, I don't have any of those. Well, then I tell them they chose the wrong parents. And that's most often the cause. So what about obstructive sleep apnea? It's one of these breathing disorders at night where you have these apneic spells where you actually stop breathing. The oxygen saturations in the body decreases abruptly, and that puts a lot of stress in the heart. And we're finding it's more and more important in treatment of atrial fibrillation. So in one study in 2003, they had patients that they were treating that all had sleep apnea. Some patients were treated with their sleep apnea, and some patients either couldn't tolerate their CPAP or weren't treated, didn't want to be treated. And their recurrence of AFib after we shocked them back into normal rhythm was much higher in the untreated population. So in the untreated population, you had 82% chance of having it again. And in the treated population, it was still possible, 40%, but it's half of what we'd expect otherwise. So how do we find it? The EKG that you'll have at your doctor's office, or you feeling symptoms, but the EKG can help document it. 24-hour or 30-day ambulatory event recorders. These are where we actually have you wear stickers that can monitor the heart for that amount of time. Implantable loop recorders, these were invented because no one liked to wear our ambulatory monitors. People, they would slip off, or, people seemed that they wanted to shower within a 30-day period or bathe. And so we just started implanting them. No, we can take them off for those brief amount of times. The implantable loop recorders we have now are quite small, almost smaller than one little spine of your fork. Okay, they're quite small. They're actually injectable at this point. So we can also interrogate already implanted pacemakers or defibrillators. In other diagnostic tests, sometimes we pick them up on echocardiograms. We see it during stress tests or left heart casts, but again, coronary disease is rarely a cause of atrial fibrillation, and it just happens to be a time that we're monitoring your heart rate and we see those episodes. So some definitions, just because we have lots of patients with atrial fibrillation, so that we can communicate with each other, we come up with definitions on how we define it. Paroxysmal just means that you have AFib that comes and it goes on its own. Usually lasts less than a few days, usually lasts minutes to hours at most. Persistent AFib means that it's capable of being converted to sinus rhythm, and that either means with medications that we can give or electrically shocking the heart. Usually we like you to be asleep for that. Actually, y'all usually like to be asleep for that. It doesn't really affect me. Permanent AFib is when we've tried to convert someone to sinus and it's just not possible. The longer time that we're in AFib, sometimes the heart can remodel, making it easier for the heart to stay in AFib and more difficult to stay in sinus rhythm. For those patients that we've given up on trying to keep you in normal rhythm, we call it permanent. Is AFib dangerous? It's the #1 preventable cause of stroke. It's the #1 preventable cause of stroke. 1 out of every 6 strokes occur in patients with atrial fibrillation, and oftentimes we find out that they have AFib after they've had the stroke and they were unaware and their physicians were unaware. Non-valvular atrial fibrillation, stroke risk is about 5% a year. In patients with rheumatic valvular disease, as a cause of their AFib, the risk is 5 times greater. So we can prevent strokes with blood thinners or anticoagulation. And the question that I get asked every day is who needs to be on anticoagulation and what the reason is. Whenever you're diagnosed with atrial fibrillation, your risk of stroke increases, like we just said. But it increases with other risk factors, okay? We used to all use what we call the CHADS 2 score, and that was C started for CHF, H for hypertension, A for age greater than 75, D for diabetes, and if you've had a stroke, then that actually counts too. And we'd add up the score, and if it was 0 or 1, we said, well, you're pretty low risk. We could either do aspirin or a full anticoagulant like Coumadin, and we'll talk about. And if it was greater than that, then we said, you know what, we'd really recommend that you be on a full blood thinner on Coumadin or one of the newer medicines. What we found, though, is that we were missing patients that we thought were low risk were still having strokes. And so a new acronym came out called the CHADS-VASc score, and it just did a couple things. If you're older than 75, then you got 2 points. If you had a stroke, again, you still got 2, but it added a few things. Vascular disease, if you had heart attacks or peripheral vascular disease or aortic plaque. It brought in a younger population, 65 to 74, and then if you're female, again, you chose the wrong parents, and you're stuck with a little bit higher risk of stroke with atrial fibrillation. Well, what were the stroke risks? So if you had a CHADS-2 score of 0, then your rate of stroke per year was 1.9%. And unfortunately, that's cumulative. So 2% at 1 year, 4% at 2 years with having AFib, and on and on. The CHADS-VASc score, though, so you can have a CHADS-VASc score of 3 and still have a CHADS-2 score of 0. And what we found with those 3, then you had a chance of stroke of 3.2%. And then with these higher numbers, it's up to 18 or even 15%, and which is just too high in our minds to not at least consider being on blood thinners. Okay. The problem with blood thinners, though, is bleeding. Okay. That's what they do. They cause bleeding, and we try to figure out our risks and benefits before we start any medicines. Is the risk of stroke greater than the possible risk of bleeding? And so we try to come up with a couple acronyms as well to help us risk stratify. The one that we use the most is in red, has bled. It accounts a lot of the things that we're accounted for in the CHADS and the CHADS-VASc, but adds abnormal kidney function, people that are on Coumadin with difficult to control INRs that we'll talk about, and then drugs or alcohol. So what do blood thinners, and when we talk about blood thinners, we talk about aspirin and Plavix, which some patients are on for their coronary disease, and those we call antiplatelet agents. And then we have actual anticoagulants. They're just 2 different types of blood thinners. When we talk about Coumadin, or I'm sure everyone's seen new commercials for Pradaxa or Xarelto or Eliquis on TV, those are full anticoagulants. Okay, the only medicine we had for 40 or 50 years was Coumadin. It's a great medicine because it thinned blood, but most people refer to it and know it as rat poison, and so it can sometimes be difficult to control the levels. It changes with whatever foods, especially with greens, and sometimes has a lot of side effects with different medicines. So they came out with Pradaxa in 2008, Xarelto in 2010 or 11, and then Eliquis most recently. It's actually a newer one out in the market, and all compared against Coumadin, they all do quite well, if not a little bit better. So what are the risks? So what they did for patients, initially when all we had were aspirin or Plavix, we had patients that were on placebo, and we compared them against those patients, and there was a 22% stroke reduction on an aspirin alone. And we thought that was pretty good, but people were still having strokes. So then we said, well, we have another agent, aspirin and Plavix, why don't we combine them? And when compared just to the aspirin group, it decreased it another 28%. Well, people were still having strokes, so why don't we try Coumadin? We tried Coumadin, and in this study, the active W trial, the Coumadin patients, it decreased it even more, 43% compared to clopidogrel and aspirin, and then compared to nothing, you'll see it's an even greater drop. The new medicine, Pradaxa, came out, the first one that came out, it decreased the amount of strokes 36% compared to Coumadin. When we compared another one called Xarelto, which was once a day, it decreased it by 12%, and then apixaban or Eliquis, that's another twice a day medicine, decreases it by 21%. And so you'll see a lot of competition on TV with these medicines. Okay, and they can be very expensive, but depending on insurances, your insurance company and some of the pharmaceutical companies, sometimes they have cards that can decrease the price. And these do not have to be monitored every week or month with INRs. That being said, yeah.
Did you ever come off of them?
So that's a great question. That's a great question. We tell people that it is long-term therapy because someone told me no one wants to be told they have to be on it lifelong. Okay, but for right now, we're saying long-term. And there's some newer things coming out. We have appendage occluders. There's parts of the atrium that actually are more frequently have clots, and we're putting little inverted umbrellas up into that area to try to keep that, if a clot formed, from it getting out. But that's not been approved really at this point to a standard population yet. So right now, unless there's a bleed, if they're tolerating the medicine well, we say long term. Okay. So how do we treat it? If you're in atrial fibrillation and you're not tolerating it very well, it's dropped your blood pressure, which is what happens in some patients. We can immediately cardiovert you in the hospital. We can shock the heart back into rhythm. Stable patients, though, we try to decrease the risk of stroke first off. That's with anticoagulation, as we talked about. And then everything else is symptom control. So in my mind, when patients come in and I talk to them about atrial fibrillation, there's two cornerstones of treatment. The first is decreasing the risk of stroke. Okay, so we're going to talk either an aspirin or being on full blood thinners with Coumadin or one of the newer agents. And once we're doing everything we can about stroke reduction, everything else is just symptom control. If you're in it for a few times a year or if you're in it all the time, your risk of stroke is the same, and it's only how you feel. For those patients that don't feel anything, they don't even know they're in it, we just slow the heart rate down. We don't want it racing wild. But if you're symptomatic from it, then we have different ways, what we call rhythm control, trying to keep you in rhythm, keep you in sinus rhythm. And the ways that we have to deal with that are both with medicines. We call them anti-arrhythmic medicines. We're not very creative, okay? Or we have ablation procedures. So this was a trial that came out in the early 2000s. It makes sense, and it made sense in a lot of physicians' mind, that if you had less AFib, even though you had some, your risk of stroke should be less than if you had AFib all the time. What we found was that it wasn't true. So in patients that were treated with a rate control strategy, meaning all we did was try to control their heart rates, and then compared them to the patients that we tried anti-arrhythmic medicines to try to keep them in rhythm, the cumulative mortality and the stroke risk was the same, was not statistically different. Now, people felt better in the rhythm control group, but the risk of stroke was the same. And so that's why I tell people, as long as we've talked about stroke risk reduction, everything else is just symptom control. So if you don't feel bad in AFib, then we don't have to do much more. But if you feel bad, we have lots of different ways to be more aggressive about it. Again, anticoagulation and then rate control versus rhythm control. No difference in cumulative mortality in that study, the AFFIRM trial, although the quality of life was improved with a rhythm control strategy. Maintenance of sinus rhythm with antiarrhythmic drugs is effective in about 25 to 60% of patients for 5 years. So oftentimes with medicines, we have to change the medicines. For some reason, the body either tolerates them or the medicine just stops working. And so sometimes we have to change different types of medicines. So what about catheter ablation, versus these antiarrhythmic drugs? There have been multiple trials, but there are just 3 that I picked out. 3 randomized controlled trials. Patients with paroxysmal AFib, that's that definition again, the atrial fibrillation comes and goes on its own. We don't have to shock you back into AFib. And they use quality of life as an outcome measure because, again, overall mortality is the same. So the total of 241 patients over these 3 studies, and they used this quality control survey, the SF36. Sounds like a airplane or a car or something. But it measured a bunch of different things: vitality, physical functioning, bodily pain, general health perceptions, physical role of functioning, emotional role of functioning, social role, and mental health. What they saw, so catheter ablation was superior to these antiarrhythmic drugs in terms of rhythm control efficacy. The catheter ablation was superior to the antiarrhythmic drugs in terms of improvement in these scores relative to baseline, with restoration to levels at or above the population norm, so people felt better, Most differences in scores were observed early over the first 3 months and remain consistent over the entire trial's follow-up. So what do we actually do, and what are our ablations all about? So these are pulmonary veins. If you're looking at me through my back, this is what the back of the left side of my heart would look like. There are 4 pulmonary veins that bring blood from the lungs into the left side of the heart. The heart's just a pump. It takes in blood on the right side from the body, the old blood that the oxygen's been taken out. The right side sends it to the lungs. The lungs give the blood oxygen. The oxygenated blood then goes to the left side of the heart, where the left side of the heart then pumps it to the rest of the body, and it's just a big cycle. So when it's coming from the lungs back into the heart is where the problem is in terms of atrial fibrillation. So there are 4 pulmonary veins. These veins are innervated with lots of different nerves, and they're muscular fibers. And the reason is the connection from the lungs grows into the heart when your body was being created, okay? And so it's a different tissue. It's not actually heart tissue when it comes in. It's lung tissue. And so these are the pebble throwers. We talked about that analogy where we're throwing pebbles into a pond. We're seeing the ripples wreak havoc in the left atrium. So these guys are the pebble throwers. And what we do is we put wires and catheters into the left side of the heart, okay? And that's a lasso catheter that we have. We see signals, and we just make roadblocks. We make big circles around these 4 pulmonary veins, okay? So we make burns just creating roadblocks around the 4 pulmonary veins. And we watch the signal go away on that catheter. And that's how we know that we have success. This is more like one of my drawings, okay, but of the pulmonary vein. This is that lasso catheter that you just saw stuck in the pulmonary vein. And these are what we're looking at in the lab. We see squigglies. So we see electrograms on the catheter. And as we burn, we're getting further and further around, all the way around the vein. You see those squigglies, or those electrograms, are getting more and more. It's taking more time from them to get across the screen, and you see less of them. And eventually, this is what we want to see. Okay? That means that we have isolated those veins, so they are electrically inert, so there's no electricity going in and no electricity going out. These are cartoons that we make in the lab. My wife thinks I'm a big dork when I show her these at home, and I'm really excited, but she's stuck with me. So left upper vein, left lower vein, a bad color choice, but right upper and right lower. Our catheters are about 3.5 millimeters wide, and so we're just making tiny little dots, little burns, and we just connect them. Okay? You can see why at this point our success rates aren't 100%, because these areas can heal, and these pebble throwers, or these veins, can still get signal out into the atrium. Okay? And so sometimes we have to go back in for a second or even third procedure. This is another, again, looking at the heart from the back. This is the left upper, left lower, right upper, right lower, and again, this one obviously took more than just one line of burns. So surgical ablation. So we're not the only game in town. Our surgeons can also do this, okay? And it was initially called the Cox cut and sew technique. And if they were going in already to do bypass surgery or something, what they would do is that they would actually cut out those pulmonary veins and sew it back together. All these lines are areas that they would actually cut the heart and sew it back together. Problem is, sometimes when they cut the heart, it's hard to sew back together. And so the mortality of these procedures was higher than the benefit that we were getting. So now they have once they're in, they have little clips, almost like my wife straightens her hair, almost like a hair straightener that just goes across the sleeves of the pulmonary veins, and that's how they work. The problem is you have to have another reason for them to open the chest with bypass surgery or something like that for that to be a viable option. Most people don't want that. We put IVs in the groins. Some people don't want that, but most people don't want the chest cut open just for one of these procedures. And I guess that's it. So who to call? So Carolina Cardiology Consultants. We have, again, as an electrophysiologist, our main office is in the downtown area. We also have an office in Seneca out in Greer as well, and hopefully we'll be coming out here shortly to Easley, but not yet. If anyone has questions or booze or... Yeah. So no. So our plumber brethren are doing a lot of theirs through the wrist, but they only usually need one IV, and we've got to use sometimes 3 or 4 and 5 IVs, and so we have to put to use more. Yeah.
If your heart's not beating, I got some good in my
Mm-hmm.
and he said my heart wouldn't beat at full capacity, so I've been on capacity for that morning. Is it ever going to get back to normal?
So it can. So when we talk about the heart not beating at full capacity, so the heart is just a pump, like I mentioned earlier. It fills with blood and squeezes it out. It fills with blood and squeezes it out. So it not at full capacity means, not from an electrical standpoint, sometimes it is, but the heart's not squeezing fully to get all the blood that comes into the heart out. So we normally call that ejection fraction, the ability of the heart to squeeze, and a normal ejection fraction is greater than 55%. Anything less than that is abnormal. We know that sometimes the heart is weak or not at full capacity because of coronary disease, because of heart attacks. Sometimes if we fix those with stents or bypass surgery, then the heart can get stronger. Sometimes though there is no coronary disease, and with those patients, like yourself it sounds like, we try medicines. Beta blocker medicines and a medicine called an ACE inhibitor like lisinopril or captopril or benazepril, or there's some other ones, Cozar and losartan. Being on those medicines can sometimes get the heart back working normally again. Yeah. What's that? So Cozar, I believe, is an angiotensin receptor blocker. I think Crestor is a cholesterol medicine. No, it's a beta blocker. I think, or Zocor is also a cholesterol medicine. Yeah, great question. So our ablations, blood pressure, okay, usually take between 3 and 6 hours, okay? Usually closer to the 3-hour to 4-hour mark, but if you've been in AFib for a long period of time, it can last a little bit longer. You're completely asleep with general anesthesia during the procedure. And that's for, so, because we make maps of the heart like I was showing you, we want to make sure those maps don't move. And so if you're fully out with anesthesia, then those maps don't move. Usually you spend 1 night in the hospital with us and you go home the next day.
Once they put you on the beta blocker,
Mm-hmm.
do you know that the rest of your life or if your heart gets back in rhythm and you go up with it?
So usually that is one of those kind of long-term medications, okay? The beta blocker. And that's because what the beta blocker does is it slows the heart rate through that toll booth or through that AV node such that the heart rate's not quite as fast. Now, what I didn't mention is sometimes when we can't get the heart back in normal rhythm and the heart's still going very fast, we can do what we call a pace and ablate strategy to get people off medicines. Because sometimes even we increase the medicines, and the more medicine, the worse people feel. Okay? So what we can...
Upper 40 or low 50s.
Is that right? And so sometimes if you felt bad with that, what we could do is put a pacemaker in. Some people don't want pacemakers, but they actually work quite well. So this AV node, this toll booth, if we burn that with an ablation, that would completely disconnect the top and the bottom of the heart. So the top of the heart would still be in atrial fibrillation, but it can't tell the bottom to go fast. The problem is it can't tell the bottom to do anything. And so we have to have a pacemaker in place to pace the heart. But by doing that, we have complete control of what the heart rate would be. So we would leave it at 60 or 70 or 80 or whatever you wanted, okay, whatever you felt better with. And we'd still, because the top of the heart was still in AFib, we'd still want you on the blood thinner medicine, if possible. But all the other medicines, the beta blockers or calcium channel blockers, we could stop. Usually we try to go through our progression of medicines or ablation before we do a pace and ablate, because at that point, there's really no going back. You have the pacemaker in, okay? It's not very often that we take those out. That makes sense.
So
Okay.
you burn on the heart to correct problems. You
That's
don't
right.
open the heart up and
That's
fix
right.
any
That's
further.
right. So I do everything that we do is through veins. Okay, it's through IVs. A pacemaker, we make a little incision, but it's not. We don't do any open heart surgery. Yeah. So our length of stay is usually 24 hours. People go home the next day. Any other questions? Yeah.
Is it normal to have fluttering once in a while if you don't have any problems at all?
Yeah. So oftentimes, you know, those pebbles that get thrown in don't start atrial fibrillation, but it does get through that toll booth, that AV node. And so what happens is it's called a premature atrial contraction or a premature beat. So instead of coming from the sinus node, it comes from somewhere else in the heart, but it gets through down to the bottom. And so you feel a normal beat. It's just a little bit quicker than you normally would. And what happens is, oftentimes, the sinus node says, if there's a beat coming from somewhere else in the heart, well, maybe I can take a little bit of a breather. Maybe I can take a rest and see if that's going to continue. And what happens is, if it's only 1 or 2 beats, well, nothing else is coming in, so the sinus node takes a little pause before starting back. And like I said, the heart's just a pump, so it fills with blood, squeezes it out, fills with blood. If there's a little bit extra time, all it does is fill. And so so you can feel that little pause, and then you feel a big, heavy, hard beat sometimes. And that's because the heart is actually squeezing more blood out. It's not dangerous, but it's very symptomatic. Okay? And if you've ever felt a palpitation or felt something with your heart, your mind has felt it, and you think about it even more, because everyone's worried, you know, for good reason, something with the heart is going on. So that's what we usually feel. Yeah. Yes. Yeah. So atrial flutter is a cousin of atrial fibrillation. So atrial fibrillation, like we talked about, was very chaotic and random, and hundreds of beats, but all like raindrops. Flutter, and we can have a couple different types of flutter, but it's going about 300 beats a minute, but in an organized pattern. So it's almost like a racetrack going around, and usually it's around the right side, the right top of the heart. Okay? If you have atrial flutter, about 50% of the time you will develop its cousin, atrial fibrillation, in the future. The problem with both atrial flutter and atrial fibrillation, again, is the risk of stroke. But unlike our ablations in atrial fibrillation that are only about 60 to 80% successful, our ablations for atrial flutter are about 95 to 98% successful. So if we burned atrial flutter, an ablation that we do on the right side, we keep you on the blood thinner for about a month, but then can completely stop it. And then if you develop AFib in the future, then we deal with that again. But in our minds, 50% of patients will have it, but that means 50% won't. And so we can get away with not being on those blood thinners.
Is that on the same as your heart racing? Someone explain
Yeah,
racing?
so racing, when I think of heart racing, I think of it kind of like as the umbrella, and all of these other things fall underneath. Atrial fibrillation, atrial flutter.
But it just lasts for a few moments, and then it goes, and then you don't have it again.
Right, so it could still be any of those. Because sometimes you feel the heart racing, and you don't know if it's AFib, or if it's flutter, or if it's something else. But for someone like that, I would ask them to wear a monitor to see if we can catch it. To see on there. Yeah. Yes, sir.
Why is the AFib more noticeable when your body's at rest, like going to sleep?
That's a great question, and I don't know the answer. What I tell people is that, you know, when you're at rest, the world is kind of at bay. You know, you have your own sensorium around you, and so you focus more on things that you feel right then. But it's not always. Some people also have more AFib or these other rhythms when they're at rest because there's a higher degree of what we call vagal tone. The vagus nerve controls the sinus node. So it clamps down when it thinks that the sinus node needs to slow down, and it releases the pedal when it wants the heart rate to go faster. So that's why our trained athletes, Lance Armstrong types, their baseline heart rate's in the 30s and 40s because they've got extremely high vagal tone. Some people, though, when they're laying down resting have higher vagal tone, and vagal tone can be a trigger for atrial fibrillation. Okay? It's not always the case. Some people drink a cold glass of water and go into AFib because it increases that vagal tone. The problem is, or the difficult thing, is that some people drink a cold drink of water and it terminates their AFib because it's a different mechanism. And so oftentimes we feel more of these abnormal rhythms when we're at rest because we don't have as much other things, extraneous things going on. But there are sometimes also actual pathophysiologic reasons why you would have it more at rest. Anything else? Yeah.
Love the handout.
You love the handout. Great. Great. Thank you.